Oh, we are live, sir.
Okay. Good evening, everyone. And I wish all of you to have a happy and prosperous new year on behalf of Indian Arthroscopic Society with office bearers. And this year to start, we have an excellent topic on cartilage session. Interestingly, the expert talk and all two case presentation also on the cartilage, so that makes more interesting. And I would like to introduce two moderators for today's session. We have Dr. Kiran Acharya and Dr. Santosh Sadanan. We know that Dr. Kiran Acharya is from Manipal Hospital, Manipal, and he is known national and international faculty, very good academician, and he is a PG teacher for many years. He has almost published 64 articles and authored 4 chapters in the textbooks, and he is well known amongst the students and also in the Indian Arthroscopy Society members. So I welcome Kiran to moderate this session. At the same time, I welcome Dr. Santosh Sadanan. He is the president of Indian Cartilage Society, and he is the medical director of Arthon Hospital, Coimbatore. He is a well-known faculty in both national and international level, published a lot of papers in index journals. I think this is a very, very interesting topics will be moderated by very good academicians of Santosh and Kiran Acharya. And we have an expert talks of Dr. Deepak. He is a founder, president of Indian Cartilage Society. Anyway, I will ask Kiran or Santosh to take over this entire session, that introduce the speakers and start the session. Thank you.
Thank you, Sundar. And it's an honor to be moderating the first academic meet of IAS of this year. And it's also an honor to present our keynote speaker, Deepak Goel from Ahmedabad. He's a pioneer in cartilage, knee arthroscopy, and sports injuries. He has done fellowships under great names like Lars Peterson, Laszlo Hangodi, and many others. And he also founded the Indian Cartilage Society in 2005 and Asian Cartilage Research Society in 2012. And he has won many fellowships and awards. He has 170 presentations to his credit. He has authored many chapters in books. He has authored books, and he's a reviewer for many journals. It's indeed an honor to present him this evening, where he would be talking to us on cartilage repair strategies and algorithm of treatment. Over to you, Deepak.
Thank you, Kiran. So, good evening, friends, and again, Happy New Year. We wish that COVID goes away in 2022, and we are all back meeting physically in person with each other and doing good academics and networking. But till then, the webinars are going to stay. So today I will be talking on cartilage repair strategies and algorithm. So I will be concentrating more on how to strategize a cartilage repair, how to plan the best treatment for your cases. And for that, before that, I have no disclosure to report. And there are certain variables when we need to plan our treatment strategy. And these variables are important to understand because each variable is going to modify your treatment plan and the way you are going to treat your cases. So the first variable is age. So look at this video. He's a young guy who had ACL tear. I did ACL reconstruction, and at the same time, I found a surprise chondral lesion. I thought that there is no other option available to me, and I'll do a microfracture in his case. 2 years follow-up, if you can see, it's a very well-healed microfracture. It's a 2-year follow-up MRI and very well-healed cartilage lesion after microfracture, which is seen over here as well. Another case, young patient, I put 2 mosaic-plasty plugs for OCD and it healed well, as seen on MRI. Another patient, huge osteochondral lesion of trochlea. We did bone grafting and ACI, and 8 years follow-up. It healed very nicely, as is evident on MRI, very well-healed congruence and homogeneous cartilage healing. Another patient, osteochondral fracture, we just sutured it with Vicryl and it healed well. 3 months post-op, you can see the vicryl mark, the needle mark, but the piece has healed well. But the beauty of healing in all these 4 cases was because of age. All were younger age. That beauty, that advantage is lost as the age advances. So we cannot have the same treatment option which we offer to the young people. The same treatment option cannot be offered to a middle-aged patient and usually not to be offered at elderly age group. And that is the important variable which we should understand. The second variable is etiology. You should know the cause because cause will dictate the treatment. If you look for causes, then OCD, trauma, osteonecrosis, and osteoarthritis are the 4 most common causes of cartilage lesion. But if you talk about small lesion, then usually OCD can cause a small lesion, a trauma can cause a small lesion, but osteonecrosis and osteoarthritis will not cause a small lesion. If you talk about mid-sized lesion, an OCD can cause a mid-sized lesion, a trauma can cause mid-sized lesion. Sometimes there can be regional osteonecrosis leading to a mid-sized lesion, but osteoarthritis will not cause a mid-sized lesion. If you look for large-sized lesion, OCD can be a large lesion, a trauma can lead to a large lesion, osteonecrosis can be quite extensive leading to a large lesion, and same is osteoarthritis. So the size of lesion will dictate the treatment. And if you know the cause, it will help you in designing your treatment plan. The next variable is BMI and smoking. A higher BMI, more than 30, I'll say strict no. Don't treat that patient. Ask him to reduce the weight first. Between the obesity patient, between 24 to 30 BMI, you may still take a chance considering other variables are in your favor, but never beyond 30. And smoking kills. If patient is a smoker, avoid him. The fourth variable, which we should take into consideration while treatment, is level of activity. If your patient has a sedentary job style, he is a clerk or a receptionist or a hairdresser where there are no high level of activities, a chondral lesion like this, which is seen on a patella, a cartilage burst fracture of patella, and if you do a abrasiachondroplasty and it will heal, as it is evident in 4 years follow-up, where cartilage has healed very nicely. However, if the patient is high-level activity patient, maybe a factory worker, a sportsman, or a dancer, then in this case, a lesion of similar type, you cannot treat with abrasiachondroplasty or microfracture. You need a hyaline or hyaline-like cartilage repair and not a fibrocartilage. And in such case, you might have to do a mosaic-plasty, or in some cases, you might have to do an ACI, because mosaic-plasty or ACI are the 2 procedures which can give you a hyaline-like repair, unlike microfracture or abrasiachondroplasty, which is more likely to give a fibrocartilage repair. The next variable which we should understand is location of the lesion. This is a case which I operated around, I think, 8 or 9 years ago. The patient had OCD of medial femoral condyle. I put 3 plugs, and if you notice, the central plug got sunk in. So I was a little bit worried at what will happen to him, but for some reason, patient did not have any complaint, and he came to me for follow-up after a few years for some other problem, and I had a chance to look at his MRI, and then I found out that he has well-healed cartilage on the medial femoral condyle. So he did well because of medial femoral condyle lesion. And I will tell you, medial femoral condyle lesions are little bit forgiving, but not the patellar lesion. Another patient who had bilateral patellar lesions, one side I operated using mosaic-plasty, and on opposite side I did ACI. If you can look at the incongruency that has been caused because of mosaic-plasty, the patient on the knee on which side I did mosaic-plasty, he had little bit problem on and off. He did well, but he was little bit unhappy because he had a comparative knee on the opposite side where he did not have any pain at all. So the location of the lesion matters. Medial femoral condyle is little bit forgiving, patella is not, and patella is a concavo-convex bone. So at that location, you need to be more careful when you are choosing a procedure. The concomitant lesions and disease are very important. If there is any immunological disease or pathological disorders, then there is a contraindication for cartilage repair. But if there are mechanical malalignment or there are other problems, say for example, in this case, there is a huge chondral lesion in medial femoral condyle, little meniscus tear, and complete ACL tear. So in this case, we decided to do ACI, little meniscectomy, and ACL reconstruction. But then we realized that he has got also tibia vara on that side. And finally, we had to do an osteotomy, ACI, ACL reconstruction, and little meniscectomy. This was the first case which was reported in English literature where all the procedures were done involving all the components or all the tissues of the knee joint. And that's why it got a place on arthroscopic cover page. So the point which I'm trying to say is that sometimes when you are treating a cartilage lesion, you might have to do other procedures as well. You have to achieve a biomechanically stable and sound joint before you do a cartilage repair. Otherwise, cartilage repair surgery will fail. Finally, size and depth of the lesions. One should understand that all the operative procedures are not for grade 0, grade 1, and grade 2 ICRS classification lesions. All these procedures are only for grade 3 and grade 4 lesions. Grade 1 and grade 2 lesions do not cause much trouble, and they remain stable for many years, though we don't have very extensive data to prove that, but these surgeries are not meant for grade 1 and grade 2 lesions, and that should be kept in mind. What about the size? Now, if you look at the literature, most of the algorithms or most of the strategies are revolving around this size. For small size lesions, some papers are for mid-size lesions and some are for large lesions. Well, what do you mean by small lesions? Different authors define it differently. But if you look at roughly, small lesion is less than 1.1 to 2 centimeters square, mid-size lesion is between 2 to 4 centimeters square, and large lesions are more than 4 centimeters square. What does that mean? That means that that lesion, if it is a circular lesion, then it will have the diameter as shown on your screen, or if that lesion is square lesion, then it will have length and breadth as shown here on screens. So you have to be very careful while measuring these lesions. But there are red flags. Lesions are neither round nor square, but always irregular. So it is very difficult to have exact measurement of the sizes of cartilage defect, either on MRI or also on arthroscopically, and you can always have a rough assessment. The second problem is that chondral defects are usually bigger than seen on MRI. So whenever you are seeing an MRI and measuring a rough estimate of size of the lesion, keep in mind that probably the lesion will be a little bit bigger than what is seen on MRI. There is no uniform formula or method to measure the lesion size. There are different scales available, and we can have a rough estimate, but not the perfect size measurement. And that's why underestimation or overestimation of size during arthroscopy is common. And the fifth biggest problem is, if you look at this nice paper which was published in Cartilage Journal 2016, cartilage defect size which are enrolled in RCTs are not representative of patients in actual practice. If you look at this data, it's clearly seen, the paper published from Germany, the defect size was similar to defect size in their national database. But if you look at other countries, the defect size in their RCTs were much smaller than defect size reported in their database. So what does that mean? Probably the selection of the cases was little biased on those RCTs. So that's why any paper you should consider with pinch of salt. Okay, so now when we consider all the variables, it's time to decide, depending upon the size, that which treatment is good for our patient. I'll go in small size, mid size, and large size. So for small size lesions, what should be our strategy? We did systematic review of literature, which was level 2 study in 2013 for microfracture. And we concluded that there are good clinical outcomes for small lesions in low postoperative demand patients and in younger patients after microfracture. If a microfracture or augmented microfracture procedure is done, it gives good relief as it is seen on this MRI, and as I showed you earlier also. So this is the case where a microfracture was done, another case, and a good healing takes place after microfracture, and which is seen on MRI. Other option can be for small lesions, just put a single plug OCT and it will heal very nicely. And both microfracture, augmented microfracture, and OCT have enough support in literature that they good healing. ACI and osteochondral allografts are probably too costly a treatment for a small lesion and too technically demanding surgeries for a small lesion, and I won't recommend that. So my treatment studies will be either microfracture, augmented microfracture, or OCT for small lesions, keeping other variables in mind. What about mid-sized lesions? So for mid-sized lesions, there are very good papers which says that if the microfracture is considered for mid-sized paper, it is a level 3 study, the results deteriorate over time. And it was a paper which was for lesions bigger than 3.6 centimeters square size. And if you cannot see on the graph, the survivorship is getting reduced over a period of time. So microfracture cases deteriorate if it is a treatment of choice in mid-sized lesions. However, there was another paper which was level 2 study by Ulstein, and he said that if patient is a low active patient, low activity demand patients, then at mean 9.8 years follow-up, results of microfracture and OCTs are safe. So this suggests that probably if you do not have any option for mid-sized lesion and if you do microfracture, they are going to do good for short time, but in low activity patient, they might be good for long-term duration. However, there was a catch. In their study, the lesion size was 2.6 to 3 centimeters square. So this lesion size is on the lower side of mid-sized lesion size, and this is not the average mid-sized lesions. So you should consider that if at all you are choosing microfracture for mid-sized lesion, the lesion size should be little bit on the lower side, as well as the patient should be a low activity patient, and then you can expect a long-term lesion. Another paper by Gudas, level 1 evidence paper, which clearly proved that results of microfracture deteriorate drastically compared to OCT in high demand patients and in athletes, and which is very well documented by this graph. If you look at this, the failure rate with OCT was very less as compared to the microfracture, which deteriorated very fast in high demand patients. So for high demand patients, microfracture is strict no in mid-sized lesions. Another paper, long-term study, which shows that consistently better results with OCT as compared to microfracture in mid-sized lesion, and it was again a level 1 evidence. And if you look at the lesion size, it was 3.6 and 3.4 centimeters square. So again, as said, if the lesion size is little bit lower size of mid-sized lesion and low activity patient, then and then only you should consider treating that patient with microfracture. Otherwise, OCT should be the treatment of choice. What about ACI? ACI has also proved good results in different literature, and there's this paper which says that ACI enhances long-standing clinical and functional results in mid-sized lesions. What about HA and BMAC? Again, this is a potentially good, promising technique, and it can give you good to excellent outcomes. There are few papers which are showing mean 8 years follow-up. But the only problem which I see with this technique is that their studies are mostly coming from same group of authors, and they are not coming from different parts of the world. And secondly, these papers are considering the lesion size of varying sizes in one study. So that's something which we need, and probably over a period of time, we will get more information about such lesions. So the decision making for mid-sized lesion could be microfracture, augmented microfracture is a high failure rate on mid to long-term lesions, and it should be done only in low demand patients and not otherwise. OCT should be the treatment of choice because it's a single stage, cost-effective arthroscopic procedure. The ideal size for mid-size varies. Different authors have suggested different size range. So you have to decide what is mid-size for you. But it can give a reasonable good congruency in mid-size lesions, and it is good for young and active patients, and it provides hyaline repair. ACI is another treatment of choice, and as size gets bigger in mid-size range, I favor ACI over OCT. There are no congruency issues with ACI. There are proven long-term results, and it also gives hyaline-like repair. BMAC, I'll say it is a limited evidence at present, but it looks very promising, and it's only a time when I think it will prove to be the treatment of choice, and we have to wait for more papers. Osteochondral allografts, it is too costly and demanding for mid-sized lesions, and I won't recommend osteochondral allografts for mid-sized lesions. So what about large-sized lesions? OCT, if it is chosen for treatment for large-sized lesion, then the donor side morbidity will be huge. Even for mid-sized lesion, it is between 5.5 to 9%. And if it is chosen for large defect, there will be huge donor side morbidity. Contouring issue in bigger lesion will be another major issue. It will be too much technically demanding if you are doing OCT for large lesions, as we have limited donor area available. I'd like to share one case way back. I've shown this slide before also. Way back in 2009, this was a huge lesion, and I thought I will do mosaicplasty in this case. And I could harvest 6 plugs, and I was very happy that 6 plugs will do good enough, and I will be able to cover the whole part. But after I implanted 6 plugs, still I was short of 1 plug, and I had a very difficult time harvesting one more plug because I had exhausted almost all the donor areas. So from that day onwards, it is a strict no for me that OCT should never be done for large size lesions. But ACI can be a good choice. There are good number of papers which says good results and good survival rate. This one paper from Augura says survival rate at 20 years was 63% even with first generation ACI. Now we do third and fourth generation ACI. The another paper which was again showing the good long-term results, and it was 12-year follow-up which confirmed a good clinical and MRI success after Macy technique. We published one paper in 2013 which was a systematic review of literature with level of evidence 2, and we had concluded that the gradual evolution of ACI technique from first generation to third generation had been beneficial, and newer generation ACI are giving consistently better results, while the limitation of first and second generation ACI have reduced. So the advantage is that at present we do not have long-term studies of third generation paper because it is too new procedure to have long-term results of third generation ACI. But at present we are now getting long-term results, even 20 years follow-up of first generation cases, and that helps us to understand that if the results of first generation ACI are good, the third generation ACI will be good while eliminating the problems associated with first and second generation ACI. Another paper, level of evidence 2, by Barry, and he said first and third generation ACI are equally effective treatment for isolated full thickness cartilage defects of the knee joint. What about allograft? If you look for evidence in Cochrane library, they will say there is no evidence from RCT to support osteochondral allograft. But there was a beautiful chapter, one of the book which I published last year, and Martin Snow published a very good table in that book. And if you look in this book, he pointed all the studies on osteochondral allograft. And if you look at here, 1 to 5 year survival, excellent survival. 6 to 10 year survival, again, excellent survival. And if 11 to 15 year follow-up, then it is moderate survival. So in his study, he proved that there are good survival of osteochondral allograft up to 10 years if it is used for large size lesions. So decision making for large size lesions, microfracture, augmented microfracture, OCT, BMAC, all are out of question. ACI is the treatment of choice. It justifies the cost and 2 stages involved if there are large lesions, and as there are no size restriction as compared to OCT, as evidenced by the list of papers which has been published on this graph. It gives superior results compared to microfracture and OCT, and it gives long-term results. If you look at this, these pictures, double OCD in medial femoral condyle and lateral femoral condyle, ACI was done on both the sides in addition to the bone grafting, and long-term results is 3 years follow-up. Both medial femoral condyle and lateral femoral condyle had very good healing. So if there is a subchondral bone involvement, you can add the bone grafting, otherwise ACI alone can be used. Osteochondral allograft, again, it's a good procedure for large size lesions. Single stage, use it when there is associated subchondral bone involvement. It again gives long survival, no size restriction, no donor side morbidity, but it has a lesser availability than ACI. Unfortunately, we don't have access to osteochondral allograft, so we don't have any personal experience, but we can get this information from international publication. So keeping all these variables in mind and treatment strategies depending upon the size, I recommend the following algorithm for patients. Adolescent patient, mostly they come with OCD and trauma. If it is a small size lesion, fix it, and fix it. Small size, big, medium size, or big size. If it is an OCD and trauma, try to fix it. If it is not possible to fix it, then for small size lesion, the treatment can be microfracture or OCD. For mid-size lesion, the treatment is definitely OCT. And for large size lesion, the treatment is definitely ACI. For younger people and less than 50 years of patients, the most common causes can be OCD, trauma, and regional osteonecrosis. If it is a low demand patient and small lesion, you can have microfracture as first treatment choice and OCT as a second treatment choice. For mid-size lesion, again, a low demand patient can be a microfracture, but I will recommend that if it is possible to do OCT, then for mid-size lesion, do OCT as the first line of treatment and not microfracture. For high demand patients, if it is a small lesion size, OCT is the treatment of choice. And if it is a mid-size lesion, ACI will be the treatment of choice. For large lesions, either low demand or high demand. It has to be ACI and or bone grafting, depending upon if there is a subchondral bone involvement or not. And if the ACI is not available or if experience is not available, and if you are experienced with allograft, you can choose to do allografts for the large lesions. So the take-home message from my talk will be: consider all variables before finalizing treatment method. Consider age, activity level, etiology, location, size, depth, concomitant, etc. before you make a call that what is the best treatment for your patients. The size of the lesion then comes for consideration. And small lesion, microfracture is the first choice. If high demand, then go for OCT. Medium size, OCT or ACI, depending upon your experience and logistics. But if low demand, you can do microfracture, but be cautious. There are more chances of failure as compared to OCT. For large lesion, ACI with or without bone grafting or osteochondral allograft, depending upon surgeon's experience and logistics. That is the nutshell take-home message that I can give you guys from my talk. Thank you very much for your understanding and for your time.
Thank you, Deepak. That was a quite extensive coverage on algorithm of cartilage management, cartilage lesion management. And we always consider you as a dialogue friend whenever we are in dilemma for these, because none of them come with a defined size or shape, or none of them come in isolation. It's usually a combination of injuries which require a customized management. With this, I see in the chat box some couple of questions already. We invite questions from the audience.
Yeah, a couple of questions. Excellent talk with the founder of Indian Cartilage Society. Good evening. One Dr. Siddiqui had asked about microfracture, but I think Sir has already answered all of them in his slides and in the discussion, and I think his views are clear as per microfracture is concerned. His concern on the long run, a microfracture does not have a good results, and already Dr. Deepak has answered his queries. The other question is, if
I think, Santosh, if you allow me, I will little bit put more information on that. So thank you, Dr. Siddiqui, for asking this question. It's really a good, curious question. The reason why microfracture has to be done sometimes is because every surgeon doesn't have availability of OATS or OCT or ACI with him. And if the surgeons who have got availability or logistics or experience of this procedure, sometimes they are in a situation when they do not have the specific instruments available with them. And those are the situations when they are caught, they have to have some other option to do it. The second could be not scientifically, but then the cost is always an issue. Microfracture is a free surgery. You are doing arthroscopy, you do microfracture, you don't add any cost to the patient. So if you do OCT or if you do ACI, there's a huge cost involved. So the reason for selecting microfracture in some of the cases is the cost, and apart from the cost, availability of the instruments, availability of the logistics, surgeon's experience, and your institution support. These are also important, and that's why microfracture is there for last 30 years and it is still staying. I hope I have answered your query.
Yeah, that was clear. Going on with that, sir, if suppose for youngsters, when they go in, if they they go in for an ACL surgery and they see a medium-sized lesion, would it be wise for them to do a microfracture and come out, or explain to the patient that later on they can go for one of these surgeries? What would be the ideal advice given to the youngsters?
What I would do is, if I have got availability of OCT with me, I will like to do OCT at the same stage. That is the best treatment, right? If I do not have availability of OCT at that time, then I have two options. Either I have to decide that patient will go for second surgery for cartilage repair, or I do microfracture at that time. The third option is that there are good number of papers where we say that if there is associated cartilage lesion and if you stabilize the joint, the patient outcome is still good, but that is for small size lesions, not for big size lesions. So I think my preferred choice will be doing OCT if the instruments are available with me at the same time.
Okay, regarding OCT, sir, how many plugs is the maximum you would prefer? As you said, you don't prefer 6 plugs. How many is the maximum you would prefer?
Now my favorite size is 8 mm. Initially, years back, I used to use 4.5 mm plugs. But now my favorite size is 8 mm, and I'm most happy using 2 or 3 plugs maximum.
Okay. And what's the minimum?
May I come in, sir? Deepak, sir, excellent
Yeah.
presentation. It's an excellent presentation as usual. I have one question for you. If I got it right, a low demand patient, 2 to 4 centimeter square lesion size, you told that you would go for OCT. But how do you get that such a big OCT? Are any other tips? Or Dr. Mendes, who proposes going for proximal tibiofemoral joint. So do you have any experience on that?
So if you look at my slide, I said that my preferred treatment option for mid-sized lesion in high demand patient or even also low demand patient is OCT. But as the size gets bigger, then I will prefer ACI. See, mid-sized lesion is not a fixed size, that 3 centimeters square or 2.5 centimeters. It is a range between 2 to 4 centimeters square by one author. Another author says 1.5 to 3 centimeters square is mid-size. So it is a varying size. So as I said, if I feel that 8 millimeter 3 plugs is going to cover it nicely, I will do OCT. But I would think that 8 millimeter 3 plugs will be too small or too short for that, then I will prefer ACI. So it's a range. The lower the range, I will go for more for OCT. The higher the range, I'll go for ACI.
Yes, on the second part of the question, Dr. Mendes from Spain, he proposes to go to get the graft from the proximal tibiofibular joint. So does anyone have?
I don't have any experience, and I think it will be too damaging a surgery.
Does somebody does it, sir? I have no idea. So
no, I have heard that. I have read some paper on that, but I'm not convinced with that, and I have no personal experience with that as well.
Thank you, sir.
I think if you want to use or spoil the superior tibiofibular joint, it is rather better to take a graft from opposite knee rather than from such a tiny joint, because you dislocate that joint, put your lateral popliteal nerve at risk, harvest a graft, which the thickness of that cartilage is not as thick as medial femoral condyle. So I think it is more damaging rather than giving any advantage. I won't recommend that.
The other question on OCT was the minimum age. So what would you recommend as the minimum age?
So what I do is on MRI, I try to see that the angle of my plug is not going to damage the physis or not. Usually if you do the full extension of the knee and if you have the vertical placement, it is far below the physis. And if my plug depth is not going to damage the physis, any age is okay for me. Same time, I will not have a longer plug when implanting in from medial femoral condyle, because if a longer plug I use, it has a chance of damaging the medial femoral condyle. So these two things I consider, and I do a good study on MRI by measuring the depth. And I ask the MRI guys to send me the CD, and then I measure it and see if it is convenient for me to do mosaic-plasty or OATS without damaging the physis. And that's the defining criteria for me.
There is another query about whether any concomitant meniscal injury would change your algorithm of treatment by Dr. Ankit Jose.
Okay, so if there is a meniscus tear, I have to treat it. If it's a meniscectomy or meniscal repair, depending upon the type of tear and other concomitants. But no, today only I did one case and there was a meniscus repair, and then I did OATS for that. So if I am able to treat the meniscus nicely, it will not change my course. Of course, if I see that the meniscus tear had caused an erosion over the cartilage and that cartilage erosion is minor, stage 2, then I won't do any procedure. But if that erosion has led to stage 3 or 4 cartilage damage, then yes, I will treat that as well.
No, another, maybe he was asking about if you do a meniscectomy or meniscus repair, I mean, do you prophylactically do an osteotomy if you do a meniscectomy?
Of course.
Is there any...
So of course, that's what I showed one case. That depends, that is the preoperative investigation you have to do. You suspect that if there is a tibia vara or something, then you have to have alignment X-ray. And if the alignment is not proper, then you have to add osteotomy also as well. I'm talking about a condition when the osteotomy, the alignment is normal. At that time, I'm talking about it.
So basically preparedness before you actually venture into doing a case, preparedness
Yes.
with respect to your armamentarium, your diagnostics, and your plan on table. These are preparedness, I think, is the most important in managing cartilage lesions.
Yeah, I'll say that before deciding for the cartilage treatment strategies in my case, I ask for lots of investigations. Sometimes, it becomes bothersome to patient that why doctor is asking for so many investigations. But I insist for that because alignment X-ray is must if you are suspecting malalignment. A good quality MRI is must. If there is a subchondral bone involvement, then you might have to ask for CT scan also. And if you're suspecting some associated pathology, then you need a battery of laboratory investigations also. So you have to do a good homework before you take a call of final treatment strategy.
I think can I emphasize one more point? I think what the Ramakant question about what is the mid-size lesion always is the question between 2 centimeter to 4 centimeter. Yes, Deepak said that it's very difficult to take more than 8 mm, 3 plugs of 8 mm. No, it comes to around 2.5 centimeter. So most often we will not be able to take more than 8 mm plug in either side of the donor side. Otherwise, it will be a big issues. So most of the cases, even we do the same like what Deepak advised. Maximum we can use a 3. If it goes more than 2.5 centimeter, then you should prefer a microfracture. Or if you had counseled the patient, we should go for a biopsy and go for a ACI.
True. Basically, I have tried taking 4 plugs also, but then I realized that it was too cumbersome. I always had a fear of damaging while taking the 4th plug. And while putting 4 plug inside, I always inadvertently had a small cut on the already implanted plug. Right. So that's like after experience of almost 15 years, I always feel satisfied and more confident when I'm able to put 3 plugs, 8 mm side. If it is more than that, I'm forced to do it sometimes when patient is not ready for ACI or he cannot afford it. But then that will not be the first choice.
Yes.
So if
if there are no more questions on Deepak's talk, I hand over the session to Santosh Sahanand for continuing with the case presentation.
Yeah. Thank you, sir.
Thank you, everyone. Thank you.
Thank you, sir. So we'll take it forward. We have 2 interesting cases to be presented. First, I invite Dr. Prashant Pandian from Coimbatore to share his screen to start with. He is from Coimbatore. He is currently doing his fellowship in Northern. He did his undergraduation in Chennai and post-graduation in Pondicherry. So let's see what he's to share with us. He's going to talk about. Yeah.
Yes, I'll just share my screen.
And the advantages of descending type of high tibial osteotomy. As he's loading the screen, there were few discussions in certain groups of Pandian wearing a stet. One of the few orthopedic surgeons who's using his stet, probably. Probably is a good clinician. Let's see what he says.
That was Daftari commenting on that.
Yeah. A radiologist. So obviously, radiologists are not happy with orthopedicians using stet, obviously.
I'll take that as a positive comment, sir. Without delaying much, I think I'll proceed on with the talk then.
Okay.
Good evening, everyone. The learner chair. Thank you for giving me this opportunity to present my case. And the topic of today's presentation from my end will be effect of ascending and descending high tibial osteotomy on Patellar height. I'm Dr. Prashant Pandian from Morthon Specialty Hospital from Coimbatore, and my co-authors are Dr. Santosh Sahanand and Professor David B. Rajan. So, as you all know, high tibial osteotomy is a popular joint preserving option, especially in the younger age group, for treating medial compartment below A. As everybody knows, what this procedure effectively does is shifts the mechanical axis from the varus position to a more valgulized position. And the main advantage advocated by this procedure is that it effectively goes on to delay the need for TKR in the younger age group, especially. So, like any good thing in life, especially a good party, there are always unwanted guests in it. And in the hero of this talk, the high tibial osteotomy, it's always the Patellar height changes and posterior tibial slope, which is always being criticized as a major disadvantage. So, clinically speaking, so what do these actually infer onto into our practice when we have an altered Patellar height? So, this can lead on to early PFOA to increase retropatellar contact pressure. And when we have an increased posterior tibial slope postoperatively, the chance of a non-contact ACL injury is greatly increased by the increased anteroposterior translation. And it can also lead on to early failure of the HTO because of the increased posterior condyle pressure. So before going into the topic per se, let me just tell you what the ascending and the descending HTO, what we had actually done is. So this is the ascending HTO, which I'll be describing about. So the literature, this is how it has been described, and this is how we have proceeded on with doing our cases. So this is the anteroposterior and lateral view on the schematics. So anteroposteriorly, what we basically do is create an axial wedge and open up the proximal tibia. So on the lateral side, so as we see, along with the axial cut, there is also an ascending limb, which basically exits behind the patellar tendon attachment on the tibial tubercle. So I'll show an example of one of the cases which we have done. This is the postoperative X-ray, and we see that this is how the reduction was postoperatively, and we used a tomofix to maintain the reduction. So this is about a short glimpse of the ascending HTO which we did, and about the descending HTO. Basically, on the anteroposterior view, it looks exactly the same as the ascending HTO, but on the lateral view, as you can see, we see that along with the axial cut, there is a descending limb instead of an ascending limb. So which exits below the attachment of the patellar tendon and below the tibial tubercle. So this is one of the postoperative X-ray which we've done, and again we used a tomofix to maintain the reduction which we had achieved intraoperatively. And one of the commonest complication in our I'm about to present a series of cases, and in our series I'm telling you one of the commonest complication which I encountered was the iatrogenic TT fracture. So in such cases, when we had an iatrogenic fracture, we also used an anteroposterior screw to fix the TT fracture. So with the data available, we went on to do a study, and the aim of the study was to compare the effect of ascending and descending HTO on the patellar height. And we hypothesized that compared to the biplanar ascending osteotomy, the descending HTO would preserve the preoperative patellar height and the posterior tibial slope parameters. So the methodology, we did a single center study from between 2018 to 22, and we included a total of 45 patients in the study, and we measured the preoperative and postoperative radiological measures, including the CDA index, the mechanical axis deviation, and the posterior tibial slope. And the inclusion criteria we used was medial compartment low A with varus alignment and complete set of X-rays with a full-length lateral, with a full-length anteroposterior radiograph and lateral views. On the exclusion criteria, age more than 60 years, BMI more than 30, tricompartment low A, inflammatory arthritis, grade 3 LCL opening, and range less than 100 degrees. Patients with flexion contracture and secondary tibia vara due to rickets or any other metaphyseal diseases. And in our case series, we always prefer the ascending HTO. This was the measure of choice. We only chose the descending HTO with patients with with low preoperative CDA, which was less than 1. So with this inclusion and exclusion criteria, this was our patient demographics. The average age was about 48, with mean distribution of male and female with almost equal distribution. And we had done about 39 osteotomies of the 45 patients, which accounts to about 87%. And descending HTO was done in about 6 of the patients, which account for about 13%. And proper preoperative planning was done, and we calculated our measurements and wedges using the Miniachi technique. And we plan to move our new mechanical axis postoperatively through the Fujisawa point. And the CDA index was calculated as shown in the X-ray, and we've used the posterior tibial cortex to calculate the posterior tibial slope. So this is a gist of the preoperative planning we did. And surprisingly, this was the results we got. The mechanical axis deviation, we found that from a perioperative value of minus 9.6, meaning that minus indicating a varus position, it shifted on to a positive state. So we produced a positive result on that to 0.08. And the CD index decreased from 0.93 to 0.83 in the entire study group. And the posterior severe slope was increased from 8.38 to 9.06. And checking for statistical significance, whether p-value set at less than 0.05, we found that only the mechanical axis deviation and CDI altered much. So with this data, we went on to compare both the osteotomies, the ascending and the descending group. And this was the results we found out in that. And we found that the patellar height decreased from 0.03 to 0.84 in the ascending HTO. And in the descending group, it reduced only from 0.83 to 0.81. Checking for clinical significance, the difference was only significant only in the ascending HTO group, whereas the descending HTO, this reduction was not really clinically significant, or at least statistically significant. And surprisingly, the posterior tibial slope did not alter much on either of the group. The ascending and the descending almost had similar non-significant reduction in the posterior tibial slope. So based on this data, before I go to the conclusion, why did we use the CDA indexes? As you all know, there are a lot of ways to measure the patellar height. The CDA, the insal salvati, and the Blackburn wheel are some of the commonest methods which has been described extensively through the literature. We chose the CDA because in case of an insal salvati, it's been properly documented in literature that finding out the distal attachment of the patellar tendon is not, it's very difficult to find the exact point where it attaches. So that was the reason we excluded the insal salvati. Whereas with the Blackburn wheel, this is an index which depends on the tibial slope. With a surgery like HTO, where we know that the tibial slope is going to be altered, we found that using this index to measure the patellar height would not be a great idea. So we went on to use the CDA as an ideal method of measurement. And we did follow all the literature suggestions which is given. We perfected a technique like using proper KOS parallelly placed to guide the osteotomy, completing the osteotomy and the posterior cortex properly with a good soft tissue release, and maintaining an opening gap ratio of 1:2 on the anteroposterior plane. So, and to summarize, what we found was the ascending HTO, there was comparatively lesser OR time, because as I said earlier, that you do definitely have a chance of iatrogenically fracturing your TT while doing a descending osteotomy. In that case, you have to go to additionally fix that fracture. So in an ascending HTO, you don't really have that complication. So you end up having a lesser OR time. And there is no significant change in the posterior tibial slope. And on the downside, there is always a risk of iatrogenic patellar tendon injury because your osteotomy just exits behind the patellar tendon attachment. So the chance of you accidentally scarring or shortening your tendon is there. And it leads on to patellar baha, and this eventually will lead on to a complicated TKR revision in the future. With the descending osteotomy, yes, doesn't alter much either of the patellar height on the patellar posterior tibial slope, and there is a decreased risk of patellofemoral OA. And the downside, you can get an iatrogenic TT fracture, and when you do get a fracture, you have to fix this with additional anteroposterior screws. And on the limitations of our study, we found we only measured the radiological outcome. The clinical outcome, we have not really measured it, and it's a retrospective study. And with this main drawback, we were not able to randomize the patient group, and there is no control on the group size. And the long-term data is not available with that as of now. And to conclude, so we conclude that the ascending medial opening with high tibial osteotomy does lower the patellar height, and there is no significant alteration in the tibial slope on either of the groups, the ascending or the descending. And after the study with this data, we now strongly recommend that the descending HTO would be a better option to avoid the chances of patellar baha in case of an HTO. And one thought which we thought we'll discuss in this learned forum is that when we did the descending osteotomy, we found that as you look closely in the X-rays, we see that the tibial tubercle is medialized. And as discussed in the literature, we all know that patellofemoral OA is at least a relative contraindication to not proceed on with the HTO. When we actually find that the TT is medialized when we're doing an descending HTO, can we really use this in case of patellofemoral OA also? Just a thought, I would like the learned panel's opinion on that, and Professor Deepak's opinion on this. So that is one doubt which I really had, which I thought would discuss in this forum. And thanks Indian Arthroscopy Society and IP Sobrai sir and Sudhara sir for giving us a wonderful opportunity to present before such a good chair. So Thanks again.
Thank you, Prashant. There's one question from Dr. Shyam, whether patellofemoral scoring was done. Any prompt scoring was done in this series of cases?
No, sir. We've only measured the radiological outcome. As I told, the clinical outcome we've not really measured on it. So we do have a Kujala score, but we've not really included in the study.
Okay. The question which is put forward by Prashant, Dr. Deepak is around. Doctor.
Hello.
Yeah, sir. His question was whether this will unload the patellofemoral joint. Will it be an advantage?
Yes, unloading the patellofemoral joint will be definitely an advantage, but the data which you're showing is, it needs to be, we need more data to confirm whether descending osteotomy is actually going to unload it. Secondly, you said that it led to medialization of tibial tuberosity, but then we need more data, how much it medialized. We need pre-operative position, TTTG distance, and post-operative TTTG distance. And then we can document that how much tibial tuberosity got medialized. And then you also need to have MRI study of patellofemoral joint to see what was the pre-operative picture and what is the long-term picture of that. So what you have said is a good point, good observation which you have made, and it can be a source of future, many future studies. But to reach to a conclusion, we need more time and more studies, I think.
Yeah, so probably a CT evaluation of pre-op and post-op.
That is the minimum thing we should do. Yeah.
Sundar sir, you want to add any points?
No, Santosh, because I don't have much experience on the descending H2O. So most of all my cases are ascending H2O. And I would also, to get some more clarity, how much patella the height was difference between the ascending and descending, Prashant?
Sir, like in preoperative planning, sir?
No. What is the post-op results? The patella bhaga, which is the complication of ascending H2O. How much was that patella bhaga when you analyzed your cases?
Yes, sir. The CDA index in the ascending group was somewhere between 1.04, the mean value, and it reduced by around 0.85. So, and on the other group, on the descending, it was not really significant. We got some 0.89 in the preoperative group, and it was 0.83 postoperatively when we took a mean of all the studies. And that's what we checked the statistical significance between these two values and found that that was only significant in the ascending group. So that's how we concluded.
Did you correlate with the sizes of the wedges to the patella bhaga? Like, we have all the cases have a different wedges, from 8 mm to 10 mm to 12 mm. I mean, did you correlate any sizes with your patella bhaga measurements?
Not exactly, sir. We just used an additional graph when we had a significant sized wedge, but I'll probably look into that data.
Yeah, better to look at that data. That will be very useful.
Okay.
Yeah, Santosh, I just wanted to ask the same question what Sundar sir asked. Was the amount of wedge made the difference in the patellar height, like amount of wedge between the groups, the amount of wedge opening?
Yeah, he told you will do the. He didn't look into that, but Prashant will look into this when he publish. That will be very useful data.
Sure.
You want to do a publication, that is the most important factor.
Very good paper, Santosh and Prashant.
Thank you.
Thank you all for the inputs. Shall we move on to the next case presentation? I invite Dr. Vishal Kasliwal to share his screen. Vishal is from Nashik, and he's been trained in Pune and Korea. Dr. Vishal?
Vishal can unmute and share your screen, please.
This case is about patella defect treated with OCT. There are a few questions on OCT and patella already, so we'll discuss about that after this case. And for the benefit of other viewers, there was a question by Tejpal Singh on when is the ideal time to take an MRI post-op for cartilage procedures. And Deepak's answer to that is 2 years is the ideal time. 2 years post-op is the ideal time to pick up a good healing in the post-op MRI. As we, Dr. Deepak, you want to add anything to that?
So what is the problem, Vishal?
Yeah, I need to quit and reopen to share my screen.
Okay.
Dr. Deepak, any other points about post-op MRI? Why you wait for 2 years? And what's the reason behind it? You want to share your views on that?
The reason why I asked for 2 years MRI is because in my initial years of practice, I used to get tempted to get MRI early at 6 months and 1 year. But at that early year, there is too much of bone marrow edema. And when you see that bone marrow edema on MRI, you almost get a heart attack that, oh my God, what is happening to my surgery? And the other problem was that the MR radiologists who are reporting those things are also not very well trained. So they used to report lots of things on that thing, and patients used to get scared. And then I did some literature search and I found out that 2 years the time when there is no bone marrow edema and you can actually see the bone healing and cartilage healing. So that's why I started taking MRI at 2 years.
All these MRI healing, you look for it by yourself, or do you rely on the MOCART score? How do you assess it, sir?
If it is a part of some study which I am doing, then of course I will do MOCART study as well. But otherwise, I evaluate my MRIs myself. I take opinion of MR radiologist, but then I think I read myself.
What do you look for in the follow-up MRI?
So what we look for is the number 1, osseous congruency. Number 2, the chondral surface congruency. Number 3 is the homogeneity of the cartilage repair, comparing the homogeneity with the surrounding cartilage, then integration to the surrounding margins. These are the 5 points which are most important to me.
Yeah, thank you, sir. So Vishal is ready. Vishal, over to you. Vishal, you can unmute your mic.
We can see your slide very well.
Yeah. Okay. Can you hear me?
Yeah, you can put in the play mode and start. Yes.
Thank you, everyone. Thank you, IAS, for allowing me to share a case here and surgical demonstration. Pertinent to the topic today, I'd like to present a case of osteochondral autologous transplantation for a high-grade patellar condyle defect surgeons. So also importantly that he had an RTA even prior to this, where he injured his right knee and had an ACL and meniscus injury, which he chose not to treat till date. On clinical examination, he had a normal alignment with grade 1 effusion. His range of motion was normal, but terminal discomfort. No obvious laxity or generalized laxity was noted. No J sign, no abnormal patellar translation. McMurray's was negative. Only clinically, lateral patellar facet, basically patellar tenderness was there, and the foot was mildly pronated. We got his X-rays. His CD index was relatively normal. No alta or baja here. His MRI gave us a surprise with a focal large area of full thickness cartilage loss overlying the lateral patellar facet, which measured about 10/8, and no significant underlying bony erosion or marrow edema. There was a loose body in the femoral intercondylar fossa, superior and medial to the PCL insertion site. So we thought surgical treatment was the way to go. Options would include debridement chondroplasty. If other options were fixation of unstable fragments, marrow stimulation techniques, mosaic-plasty, or OATS. Out of the equation here, but other techniques also known are allograft techniques, ACI, Macy, and cartilage unloading procedures to relieve him of the symptoms. We relied on a very simple algorithm that it was a small lesion less than 2 centimeter. So either go for a microfracture or an OAT. We went in with the OATS procedure. Here we would like to discuss the pre-op plan as we've discussed till now. And I think I would directly go to the surgical demonstration here. So we put up his MRI here showing an inferior-lateral lesion. On the scope, we found loose body in the notch, and the cartilage defect was seen. We just remove the loose body arthroscopically. Patient was supine under tourniquet. We decided to fix the lesion with OATS using open procedure arthrotomy. A medial parapatellar approach was taken. As a first step, we did a debridement of the condyle lesion. Curettage was done till fresh edges. And of course, the size of the lesion grew larger than mentioned previously in the MRI, which was around about 12 millimeters by 12 millimeters in dimension, approximately. So we used a DePuy corset here. So we've taken the drill guide, kept it perpendicular to a lesion. We've prepared the graft recipient site first, kept the drill guide perpendicular and drilled the 6 millimeter drill bit to a depth of approximately 14 to 15 millimeters, making sure not to, so that a plug doesn't become very proud. Then we went on to harvest the graft above the sulcus terminalis on the lateral femoral condyle lateral edge, and again harvested the graft to a depth of 15 millimeters. Here we turned the graft harvester clockwise and counterclockwise 180 degrees to remove the graft, which came off very easily. So you can see clearly that it is the non-weight bearing area from where we have harvested the graft. Then from the graft recipient, we are now going to transfer without hammering, slightly pushing the graft onto the recipient site. Making sure that there is no overhang and the cartilage is not proud. So adjacent to that, using the drill guide, we drilled another hole and repeated the steps sequentially. In the end, this is the final outcome. It is very difficult to match the shape of the patella accurately, but we tried our best. This is the current outcome of the patient. He sent his video from home yesterday. Most of rehabilitation we gave him CPM. So here are a few papers. Kudas et al. Showed that 96% good and excellent results in OATS, whereas there was only 52% good and excellent result in an athletic population with microfracture. Lynch et al. Found that in comparison with microfracture, or ACI OAT had a better clinical result with a better return a level of a rate of return to sports and maintenance of pre-operative sports activity level. A surprising paper by Astur et al., where they compared samples between size of the lesion, location of the lesion, and number of oats used. They found no differences in functional outcomes regarding the defect size, but better outcomes were seen in patients with an isolated lateral facet lesion, which our patient had. They routinely got an MRI at 6 and 12 months, and 83% of the plugs had complete osseous integration at 6 months and 100% at 12 months. Know it all in their study revealed that patients who received OAT as an isolated procedure presented with better procedures. So we are all talking about Patellar procedures here. Coetol, it's a very important conclusion, demonstrated that a misalignment of only 0.5 millimeter above native cartilage increased the contact pressure on the plug's cartilage by 50%. This is one of the most important factors that may determine the success rate of oats is the correct placement of the bone plug. It should not be left too proud. Oats tend to deliver good and excellent outcomes in knee, demonstrating that outcomes tend to be better in the femur compared with patellofemoral compartment, 91% versus 74% in some papers. So osteochondral lesion of the patellofemoral joint is clinically challenging because of inherent nature of the articular cartilage, complex morphology and heterogeneity among the patella shape and size amongst patients, high stresses, which is almost 6.5 times the body weight. The pressures are altered by malalignment and maltracking, and of course, relatively worse outcomes compared to tibiofemoral joints. The best outcomes were seen in lesions less than 2 centimeters, seen in lesions where a single plug was used. There were no associated realignment procedures. Isolated traumatic lesions showed best outcomes. Inferior outcomes were seen in lesions of both medial and lateral facets together, patients more than 50 years of age with larger surface area, and with patients who required 6 or more grafts, which basically increased the donor site morbidity. Complications seen was stiffness, requiring MOVA in up to 9% of patients. Graft failure rate was anywhere from 0 to 8%. So in conclusion, this procedure significantly improves patient-reported functional outcomes, including Lishon, IKTC, Kujala, Tegner, offering a good rate of return to sports both for general and athletic population. Oats should be offered to patients with high-grade patellochondral defects when non-operative management has not proven successful in managing anterior knee symptoms. Based on current evidence, they concluded that MRI should be conducted at the 12-month follow-up to assess plug integration and plug's cartilage integrity. Thank you.
Thank you, Vishal. Good presentation, interesting case. Was any TTTG was mentioned? Sorry, I missed it, I guess.
My radiologist always does measure the TTTG without us asking to.
Okay.
He had not done it this time. And I do not remember, it was not mentioned in the MRI report. We did not ask him specifically otherwise to do it at that point of time. So I do not have the TTTG distance here.
Now, this unloading osteotomy for patellofemoral, to decide whether any unloading is required or not, TTTG is mandatory. So with that only we can decide, is there any additional procedures required or not? So like an alignment weight-bearing scanogram, for a patellofemoral, you need a TTTG. If possible, a tracking CT is required before venturing into treating the cartilage defects. So like ignoring a scanogram. It's like ignoring a scanogram in a medial OA. So in this case, it didn't look like lateral tracking, but that is mandatory. It should not be missed.
Yeah, I agree.
And, is any other reason you chose to do OATS rather than other procedures?
Overall, I thought OATS would deliver a better result than microfracture here. And that's why I thought, because microfracture, I thought might not really.
Yeah, okay, not the microfracture, which we've discussed today, like an ACI or a BMAC.
Sandosh.
Yeah, ACI availability and costs, both were an issue at my center. So
I want to hear your view and Deepak view on this case. I mean, what you would have done if you were seen this case in your practice?
Thank you, Sundar, for asking. Shall I answer that?
Yes, Deepak, please.
Okay. Dr. Kasliwal, excellent case presentation and excellent demonstration of technique. I have few concerns. If you look at MRI, I think the patient's trochlea is dysplastic and it may be type C, because I can see hypoplastic medial trochlea and more prominent lateral trochlea. The second reason is that the patient got lesion on lateral patellar facet. That means that his patella, lateral patellofemoral compartment was overloaded. And that again says that probably the prominent lateral condyle and hypoplastic medial trochlea was maybe one of the reason. And thirdly, if there is a lateral patellar pain and lateral patellofemoral overloading, in that case, I will choose to take a graft from medial trochlea and not the lateral trochlea, because lateral patellofemoral joint is already overloaded. So this is the little bit observation which I could make from your talk. But of course, you are the better judge because you have seen the patient whole and we are just seeing the few slides. But that, I think that's my opinion.
Regarding me, I would have chosen a cellular procedure. I would have preferred to do it arthroscopically, probably in a prone position. Prone scopy, dry scopy during the cellular procedure, probably a single stage procedure.
So for patellar defect, Santosh, whether you prefer the OATS or ACI, because sometimes we are very thin. We have a very thin patella in Indian population.
Yeah, OATS we need for an OATS in patella we need to open and flip the patella, so it's a medial parapatellar big incision. So for a trochlea we can still do it with a suprapatellar small incision. I don't prefer doing the full medial parapatellar open. So try to do it scopically. Being a medium-sized defect, prone dependent ones have given good results. So
Santosh, is there any literature available for treating conservative versus operative management for patellar defect, like small defect like less than 1 centimeter like this?
Yeah, small defects, microfracture definitely does not give good results. So first choice is cellular procedure if surgically managed. So small defects, there are evidence that on the long run they do well. Small, medium-sized, it's somewhere debatable. So small ones do heal well. And in the initial slides of MRI, which I saw, I thought it was not grade 4, but you had shown loose body and it was a grade 4 when you went in. But the MRI, I thought it was like more like a chondromalacia. It didn't look like a grade 4, but as you went in, it was a loose body. So it was a little surprising.
Sir, I have one doubt. In a bone like the patella, where it is the contouring is a problem, the OATS is basically dependent on matching up your level. When you put the plug, it should be flush with the bone. It's practically not possible to get that on a patella. If at all you're planning to go for a procedure, why directly consider ACI, not consider OATS at all? And is there any literature evidence saying that ACI is definitely better than OATS in case of patella, especially?
I'm not aware of that comparison in patella OATS versus ACI. There are a lot of literature comparing OATS and ACI, which says it's almost the same, but I mean, biopsy-wise, histologically, it's never the same. It's OATS is always higher in cartilage, and ACI is higher in like cartilage. But for the patella, I am not aware of the literature. And as Vishal had shown, he had sunk it slightly inside just to make sure it is not prominent. So the outcome is good. So make sure it is not prominent. In patella, it's very difficult because of the ridge. It's almost impossible to reconstruct that ridge right in the center. So towards one facet, it's okay. His lesion, which Dr. Vishal has shown, is almost in one lateral facet. So probably that's the reason he's able to.
He did sink in because he took, I think, even the donor, he took, I think, 15 mm. So in general, we tend to take in femoral condyle like 1 or 2 mm lesser than your inserting size. So I think that's why you wanted to make sure that the flesh goes slightly deeper than the normal surface.
Here I will agree with Santosh's point, because the defect is only on one facet, so the congruency issue will be less. If the defect is on the apex, or if it is considered like in the central part of the patella, where the defect is partly on medial facet, partly on lateral facet, and partly on apex, then congruency is much bigger issue. And for this size lesion, apart from the concerns which I raised, I think Oates is a good choice, because it's a very small lesion, 2 plugs, and he achieved a good congruency. So I think for such a small lesion or such small to mid-sized lesion, Oates is definitely not a bad procedure. However, Dr. Kasliwal, again, the size of arthrotomy which you did is not needed. A mini parapatellar medial arthrotomy is good enough. If you do a mini parapatellar arthrotomy, you can very well evert the patella. You need to remove certain plicas. You need to cut the superior plicas and some lateral plicas. And when you release that, and you have to release little bit Hoffa's fat pad, and when you release that, you can evert the patella even with mini patellar arthrotomy, medial parapatellar arthrotomy, and you need not do the large arthrotomy.
Okay, sir. Thank you.
And just to add few thoughts, I've always wondered whether we can do retrograde osteochondral transfer, probably drill from front of and
Santosh, you want to do this? Santosh, you want to do this for many years.
So I'm just giving ideas so that somebody else is bold enough to do it.
Santosh always like a retrograde.
Retrograde, yeah.
And
public forum.
yeah.
He always finds out a new way to do the things. Good.
There is one more question from Ankit Jose. What was your post-operative rehabilitation in your case? I think for question to Vishal, I think.
Vishal.
Yeah, so I started on immediate range of motion as tolerated, ice packs, kept him partial weight bearing for a week or two, and locked his knee in extension while walking in a hinge knee brace, and then full weight bearing thereon with standard exercises, quadriceps standing exercises.
So when did you allow squatting? Because the video which shows follow-up of how many months?
That's 6 months recent.
Okay.
So I did the procedure 6 months ago. He did not come for follow-up at all. And I asked him, please send your recent videos. I have a presentation. He sent me this.
Okay.
Yeah, patellofemoral rehab is different. So weight bearing is not a problem because it's not exactly in the weight bearing position. Closed chain is the key here. So when to start closed chain? Early mobilization, maybe CPM are the key issues here. Weight bearing is not an issue. Closed chain activity is the thing which should be delayed. That's what Dr. Vishal has done.
Okay, Santosh, I think there is no further. Any other questions? Can we conclude?
Sure, sir.
Okay. And thank you, everyone. I think today we had an excellent day with a superb presentation by none other than the cartilage expert, Dr. Deepak Goyal. And we had excellent discussions on the talk. At the same time, I congratulate Prasant for presenting an excellent case series on this high tibial osteotomy between ascending and descending, which we learned a few points over here. And of course, another case demonstration by Dr. Vishal, superb case. It's involved with a lot of discussions with the management point of view and with the wonderful result too. At the same time, I want to thank Kiran Acharya from Manipal and Santosh Sahanand from Ortho1 Coimbatore for excellently moderating this entire session. Hope all of us, hope everyone are benefited by these talks and the discussions. Thank you, everyone. Once and all, good night.